He will not force
First of all, thank you ever so much for having me to come and speak to you this morning. I think the first thing I'll say is, if it's okay with everyone, if there's any questions at any point, just put your hand up and we could just stop and chat as we're going. So, I'm going to spend the next probably 40 minutes talking about haemodynamics, monitoring, and more importantly, why it matters and why we can help make a difference to patient care. First thing to say is, what on earth are haemodynamics? And you can Google this, or it's up in the book, but haemodynamics is all about blood flow to organs. And it's something that, as intensivists, we've been trying to get right for a long time now. And if we're going to talk about haemodynamics, I'm clearly not trying to be condescending, but just to point out what we tend to do on ICU. I know most of you here will be very familiar with this. On ICU, we look after all sorts of things. We look after sepsis. We're now a major trauma centre, so we look after quite a bit of trauma. Head injuries or intracranial events are quite common. And of course, a lot of surgical patients, either elective or maybe emergency. A lot of patients get referred to as looking like this, perhaps with an obs chart looking like this, and this is a very, very common thing as an intensivist. And then often they end up like this, and patients in ICU can be plugged into all sorts of machines, sometimes upwards of 7, 8, 9, 10 infusions, and the more they stack up, the more you start getting worried. They can be on fancy ventilation modes, which can have all sorts of effects of their own, and lots of other machines, maybe renal replacement, maybe nitric, maybe circulatory assist devices. And we put up lots of numbers on the screen, and we sort of stand at the foot of the bed and scratch our chin and try and look clever and try and think that we know what's going on. But sometimes it's really hard to actually work out and piece together. Some of our sicker patients can have up to maybe 20 blood gases a day, and off the lactate side, we might try and work out why. And of course, a huge number of times we get called to patients because the blood pressure is low, and we get asked, why is the blood pressure low? Which brings us on to shock, and this is going to be a big thing we'll be talking about this morning. And again, shock is basically just inadequate organ perfusion, and you can pick this up clinically. So it could be poor perfusion to the skin. So I think most of us have seen this kind of picture. Maybe poor perfusion to the kidneys. So someone is oliguric or possibly even anuric. And if it goes to the CNS, you might have a patient that's utterly incapable of any sort of rational thought, and then you get labelled as confused. So shock you can think of in so many different ways, but a real nice way of thinking of shock, and this is going to fit in with what we're talking about this morning, is shock can be hypovolemic. Pardon me. So hypovolemic, so that could be maybe your patient that's just had a PPH or just transected their aorta, for example. Maybe someone who's very, very dehydrated. It can be distributive. So that could be someone with sepsis or maybe anaphylaxis, maybe a high spinal cord injury. Shock could be cardiogenic. It could be left-sided, it could be right-sided, maybe biventricular. And again, that could be many reasons. It could be ischemic, it could be a septic myocardium, maybe a viral cardiomyopathy. We see it for all sorts of reasons. And shock can be obstructive. It's obstructive shock, we tend to think of things like PEs, tension pneumothoraces, maybe cardiac tamponades. And it's a really useful thing to do it in this sense, because every form of shock has its own set of symptoms, signs, and also findings. And if you know which kind of shock you're dealing with, then you know how to treat your patients. And of course, you can have more than one kind of shock at a time. So to try and make this a little bit more interesting, rather than me just standing here and rattling on, I thought we'd go through some clinical cases, all stuff that we've seen here recently in the John Radcliffe Hospital. So a major trauma centre. So here's a recent patient, he's 36. He was hit by a car, intubated at the scene, and he gets a trauma call, which is routine now. So if you come to resus, tachycardic, hypotensive, cold and shut down, they all get a venous lactate at the front door now. So venous lactate of 4. So you start thinking maybe something's going on. You do your primary survey, there's no tension pneumothorax, And as per protocol, someone activates the major transfusion policy. Now, is there anyone here who's done any echocardiography? Please do put your hand up. So this is what's known as a parasternal short axis view of the left ventricle. And this donut here is the left ventricle, and the black stuff in the middle, that's the blood. This is the muscle. And most people look at echo reports, they look for one thing, which is ejection fraction. And ejection fraction is just the fraction of when it's full versus empty. So can I convince you all that this is contracting well? The black stuff in the middle is getting smaller and bigger. So if this is a normal heart, if you come to resus and you put the probe on, you might see something like this. So once again, here's the left ventricle. And can I convince you that the stuff in the middle here is almost disappearing? And some people say the ventricles are kissing. And this is a classic example of hypovolemic shock. Now you might look at this and think, but this is obvious. I mean, look how gross that is. But you'd be surprised sometimes on the ICU when you've got a lot of things going on, a lot of very, very confusing numbers in your monitors, and you can put a probe on and you can pick up in seconds that someone is empty. A really simple answer, but it really helps you clinically. So we can come along to exactly the same patient, exactly the same set of circumstances a day later, and you could have, let me just remind you again, that's a normal heart, and you could have this sort of thing. So this looks a bit strange, but this is just the same view. This is a parasternal short axis view. There's your left ventricle. That thing on the side there is your right ventricle, and you've got a big, big thing going around it. So this is a pericardial effusion, and this is a tamponade. And again, if you're in a resus with this patient, he's got a collar on, he's intubated, he's ventilated. There's about 15 people around the bed. It's very noisy. It can be really hard sometimes to tell the difference, but you can tell this in seconds just by performing a scan. So in this case, you've got obstructive shock. And this really matters because this is going to help you decide whether or not maybe on one hand you might be transfusing and doing maybe a laparotomy versus maybe using a needle to decompress the pericardium, or nowadays maybe something a little bit more dramatic. But it's a really, really powerful thing to be able to do. Let's take the septic patient. Here's a guy who was in, it's about 7 months ago now. So 34, he was a farmer, which is not really relevant to the history. And his story was he got out of his tractor and felt a sharp pain in his leg, which felt like a muscle tear. He waited a few days, felt a bit unwell, went to see his GP. Now I'm not saying for a second that his GP should have done an echo, but had the GP done an echo, just to remind you again, this is a normal heart, so this is a parasternal long axis view. This is the left atrium, going through the mitral valve, into the left ventricle, out through the aortic valve and into the ascending aorta. And if that's a normal heart, and if the GP had done an echo, he or she might have seen something like this. So if you look at the one on the left, the normal one, if you think of the ejection fraction again, that black stuff in the middle of the blood is kind of getting smaller and bigger. On the right, it's completely collapsing. So this guy would have shown early signs of sepsis. In early sepsis, you lose your afterload, and you get distributive shock, and you get this kind of hyperdynamic collapsing heart. And we find this really useful in ICU because, as you all know, ICU patients are complicated, you've got lots of things going on, and this can be a really subtle early sign that actually your patient is vasodilated, which can often be caused by sepsis. But let's take this story forward a little bit. We met this guy when he came into hospital and had his leg debrided. He was very sick, he'd been in theatre, he came around to the unit, and he was looking dreadful. So tachycardic, hypotensive, not really passing urine, very, very positive. They sometimes are in early sepsis, on what is a lot of noradrenaline, so a lot of vasopressor. And unfortunately, the lactate, which was raised, was heading the wrong way. And so you come in the morning, you get this sort of picture. And then people start standing around the foot of the bed and saying, how should we treat him? Some people say, let's give him steroids. So what's the evidence for steroids in sepsis? The answer is there isn't any really. It can reverse shock a bit earlier at the expense of greater infection, but no one's ever shown them truly to affect outcome. But some people might give steroids. Some people might reach for vasopressin. Vasopressin is similar to noradrenaline. It acts on different receptors, but it sort of squeezes as well. Not much evidence it changes outcome. More fluids maybe. Maybe 8 litres is not enough. Maybe even more noradrenaline. We're already hammering it. Why not increase it? So just to remind you again, this is a normal heart. There's the left ventricle. And there's your blood in the middle coming and going. So this is what this guy's heart looked like. So can I convince you all that the bit in the middle, the blood, isn't really getting bigger and smaller? In other words, the ejection fraction is reduced. So this guy's got septic cardiomyopathy. And we actually now know that up to 2/3 of patients with sepsis get this. They get pump failure. And it's really important to know, because actually what this guy needs is none of those things. What this guy needs is inotrope. And so we took a guy who was sick, deteriorating, and with inotrope, we had him off ICU within about 6 days. And it's very difficult to do this without an echocardiogram. So sepsis, we're all taught, is distributive because they dilate. We're taught it's hypovolemic because they get very leaky. But it's important to be aware that 2/3 of these people, it can also be cardiogenic. And unless you look for the underlying causes and for the pathology, you won't be able to treat them properly. So here's a common story for anyone who's ever been near the West Wing, near the neuro ICU. A young patient, female, isolated, traumatic head injury. This usual common thing, the ECG is a little bit weird, no one's really too sure why. There's a bit of a troponin, everyone always argues, well, why, what does that mean? And the noradrenaline's going up a bit, and as per neuro ICU, we try and maintain a cerebral perfusion pressure, and they're struggling. The NORAD's going up, the fluids are pouring in, and they want to be careful with fluids in this case, because they're worried about cerebral edema around the injury. So again, some people might say, so what, who cares, it's just incident of finding, ignore it. Some people might say, okay, you want to get your CPP up, let's give more fluid. Yes, you'll get edema, but we need to aim for this static target. Let's increase noradrenaline. Someone at the time suggested, well, the troponin's a bit up, there's ECG changes, let's give antiplatelets. Let's do an angiogram. Someone who's intubated and ventilated with a bleed in the brain. So if this is now, ignore the one down there for the time being. If this is your normal scan, this is now called an apical 4-chamber view of the heart. This is the easier one to look at because it's logical. So here's your left ventricle, and here's your right ventricle, your left atrium, and your right atrium. And this is what a normal one looks like. This is what this patient's one looked like. And can I convince you that it looks a bit like this thing over here? This is an octopus trap. Now in Japanese, this is called takotsubo. And that's why we call this a takotsubo cardiomyopathy. Now, it's something that we've known about for quite a few years. And again, you might say, so what? Well, the answer is, actually, it does matter. So it's something that we're finding out more about. So here's a paper, it's about 3 months old now, from the New England Journal. This paper is the largest case series of takotsubo patients. They looked at 1,750 patients. And what they found is this thing that in the past people have tended to dismiss actually really matters. Because when they looked at them in hospital, they found that they had their in-hospital death was the same as a matched group of patients with acute coronary syndromes. And it also matters when they go home. So when these guys go home, they also do very badly. What do we do about it? Well, it's too early to say. There's a hint that maybe they do better on ACE inhibitors. But certainly the days of saying, oh, well, it's a takotsubo, so what? Those days are behind us now, because these patients do badly. So it's important to know about it. This is the classical thing everyone always talks about. So she's young, she's in the ED, she collapsed, short of breath, not much of blood pressure, the lactate's raised, you have clear chest, not auscultation, it's a sudden history, you put the probe on, and you see this kind of thing. So again, to remind you, here's your short axis view. The left ventricle is nice and round, it's a donut. The right ventricle is this little thing on the side here. And can everyone see the difference in this case? So your interventricular septum is flattening. The right ventricle is very, very dilated. So with that story, with the lack of clinical signs when you listen to the chest, and with that scan, I mean, this is very suggestive of PE. And when you look at PEs, you can stratify them as mild, moderate, and severe. So this is what's known as a severe PE. And if your patient's too sick to go to a CT scan of a CTPA, this might be the thing you can hang your hat on to say we should thrombolyze. So this is a case of obstructive shock. So a lot of you will be sending your patients to ICU after surgery, and this is a real common scenario. So let's take a 64-year-old who's been in ICU for 4 days, had laparotomy, fecal peritonitis, and this is what we look at and say this is just an ICU chest X-ray, isn't it? It's just mucky. It's often quite hard to know why it's mucky. Patients are often intubated, maybe on a bit more adrenaline, a bit of oxygen. So what can we do about this? Do we just say it's mucky, or can we try and unpick it? So this is where we start talking about diastolic function. Everyone always worries about systolic function with echocardiography and with the heart. But it's important to remember that just as the heart needs to contract, it also must relax. And in fact, it takes more energy to relax than it does to contract. So in health, your left ventricle is healthy and it relaxes so well that it actually sucks blood in from the left atrium. You actually get a bit of negative pressure here. And that's the healthy state. When your heart becomes unhealthy and it starts to stiffen, and it can do this for all sorts of reasons. It can be patient reasons. Maybe a patient is hypertensive, got a bit of LVH. It could be something that we're doing. It could be we're giving not too much noradrenaline, or maybe the ventilator settings are off. But when your heart starts to thicken like this, it doesn't relax so well, and the pressure in your left ventricle goes up, and it goes up so much that your left atrium has to actually force blood through, and it pushes it through. And the problem is, for your post-op patients, is that if it forces blood this way, it's going to leak back that way, down your pulmonary vein. And on the end of your pulmonary vein are the lungs, and on the end of the lungs are the right heart. So we can measure this very easily on echo. We can use something called Doppler. We can look at the blood flow through the mitral valve. We can use something called tissue Doppler, and we can look at how well the left ventricle actually relaxes. We can look at the Doppler of the pulmonary vein. If you remember, at the end of this are the lungs. And we can integrate all this and come up with a good idea of whether or not the filling pressure, which is otherwise the left atrial pressure, or you can think of as what we used to call the wedge pressure, those of you who used to use swans, we can say it's normal or it's raised, and this can be really handy. Because if you come along and say that your filling pressure is normal, then that mucky chest X-ray that you're looking at could just be bronchopneumonia. It could be ARDS, what people tend to refer to as this phenomenon of leaky lungs on ICU. And those are going to have different treatment strategies. If you find that your left ventricular filling pressure is raised, again, it's going to change your treatment. It could be raised because your systolic function's gone down. Here's a similar one you saw earlier. There's your short axis view. With the black stuff in the middle, the blood, it's not really getting bigger and smaller. You haven't got much ejection fraction. It could be raised because you're giving too much of this, in which case you need to diurese. It could be raised because your left ventricle is genuinely stiff. You've got genuine diastolic dysfunction. Or here's a recent patient we had. There's your apical four-chamber view again. Here's your mitral valve. That's your anterior leaflet. And that little thing there flapping around is your posterior leaflet. So we talk about mitral regurgitation. We talk about mild, moderate, severe. Well, this guy had torrential MR. I mean, it's just off the scale. And so this guy had a mucky chest X-ray and had a raised filling pressure because his MR had ruptured. So his mitral valve ruptured, so he had an urgent MVR. So that's a little bit about what we're doing at the moment with echo and ICU, but what's coming, what does the future hold for us? Well, the first thing is the kit. I mean, 15, 20 years ago, you had to get in the lift and you had to spend 20 minutes booting your machine up. This is before my time. Whereas nowadays, in fact, we've got a guy come to unit at 11 o'clock this morning to show us this sort of thing. Because nowadays, you can run down the corridor to A&E, to the ward, to SCU, and you open this thing and it boots up in about 2 seconds, and you can answer questions then and there. And that is just so powerful. So that's one of the things the future holds. At the moment on ICU, we're using this sort of thing. The other thing to mention about the future of echo is this, and it's the only equation I'm going to put up because it's too early for equations. But one of the things we try to do as intensivists, and indeed as anaesthetists, is we try and deliver oxygen, because delivering oxygen to tissues is what we try and do. And the equation is pretty simple. If you want to deliver oxygen, you need a cardiac output to do it, and you need to deliver some hemoglobin that is saturated. So for many, many years now as intensivists, we've tried to make this work. We've tried to play with cardiac outputs to try and change outcomes. And the people that taught me ICU, they often started off doing it with this sort of thing, a Swan-Ganz catheter. And as kit has evolved, or maybe as evidence has changed or not changed, it's got less invasive. I'm sure a lot of you have come to ICU and seen patients with this kind of thing in, an esophageal Doppler. And it's got even less invasive now. Now you get this machine which just piggybacks an arterial line, uses a magical formula and comes up with numbers. Whether or not they're random or not is up for debate, but it comes up with numbers which will give you cardiac outputs. It's important to say that no one's ever got this to work. So there's no good study that says that cardiac output monitoring works. And here's a really good recent example. So almost everyone in the room would have seen this somewhere, possibly on the wall in A&E. This all comes from 2001, a guy called Rivers in Detroit, who published this incredible study saying that if you've got sepsis, you should do this to your patient. You should give them a CVP of this, a map of that, aim for mixed venous sats of this. If you can't do it, give blood, give dobutamine, so on and so forth. It's an amazing piece of work. The main reason it's amazing is because all of us now know about sepsis, and we look for it, we pick it up, and we treat it. Does it work? Well, there were 3 studies last year in the New England Journal. There's an English study, an Australasian study, and there's a study from America. And the answer is no, it doesn't work. Because the days of looking at static numbers and trying to treat patients, they're not really there anymore. And here's a real simple possible explanation. Because if you have a septic patient, as we looked at earlier, how do you know in your studies if it's this they've got, are they empty? Or if they've got septic myocardium, and you never know this unless you echo. So all the cardiac monitoring we've done so far, you could say, is a bit like this. It's a bit like looking through a blind, but this really complicated system, trying to understand it without actually fully looking at it. And then when you treat patients, saying that everyone's a clone. Everyone needs a CVP of this, a map of that. Whereas actually, we know that's not the case, is it? Every patient's different. And I think the most useful thing about echocardiography in ICU is if you learn to echo, it's not just plugging a machine and turning a button, it's learning how to acquire images. And through that process, you need to learn about cardiovascular haemodynamics. Therefore, what you're looking at, hopefully you understand. If you understand it, you can interpret it for what's going on in front of you, and then you can tailor your treatment. And that is really the power, I think, of echocardiography in ICU. And that's it. Thank you very much.